Okay, we've got a big presentation ahead of us, so I don't want to take too much time waiting, so we'll just kick this off. Thanks so much for joining us today. My name is Jasmine. It's my pleasure to introduce today's Bruyère Talks Research webinar series, building and implementing both evidence-based and patient-centered care for delirium in palliative care. First, I just want to note that this presentation is being recorded. The Q&A is also going to be held at the end of the session, so you can submit written questions throughout the presentation via the Q&A icon at the bottom of the window, or feel free to use the raise hand icon at the end during the Q&A portion. If you want to ask a question live, we will unmute you. With that said, I'd like to introduce our speakers today who bring both clinical and research expertise to our talk today. First, Dr. Peter Lawlor is an attending physician on the palliative care unit at Bruyère. He's also a professor in the Division of Palliative Care and the Department of Medicine at the University of Ottawa. Dr. Lawlor is a senior investigator here at the Bruyère Research Institute and a clinical investigator at the Ottawa Hospital Research Institute. And his interests include cancer pain management, cancer pain assessment and classification, and cognitive dysfunction, particularly with respect to delirium in palliative care. Our second speaker today is Dr. Shirley Bush. She is also an attending physician on the palliative care unit at Bruyère. She's an associate professor in the Department of Medicine, the Division of Palliative Care at U Ottawa as well, and is an investigator with us at the Bruyère Research Institute and clinician investigator at OHRI. Her research interests include delirium management and guidelines and the experiential impact of delirium on patients and their families. So really well versed in what we're going to be talking about today. And with all that said, I'd love to turn it over now to our speakers. Dr. Lawlor, take it away.
Great. Thank you very much, Jasmine, for the nice introduction. Just want to declare that we have no disclosures, no conflicts of interest or financial affiliations. We do have some. Next slide, please. We do have some grant funding. We're very appreciative of the support that we've received, particularly over the last decade, from the Bruyère Research Institute. We've also had support from the Department of Medicine. And more recently, we've been reasonably successful in terms of the Bruyère Academic Medical Organization incentive grants, and also again the Department of Medicine this year, the Ottawa Hospital Academic Medical Organization, and most recently CIHR for the Dex Metatamine study. Next slide, please. So both Shirley and I work in palliative care, and you know, I could show you a slide with a very extensive definition, because most of the definitions are very, very lengthy. I found this one from the Health Canada website. It's not really a definition, but it's more just pulling the information, and I thought it was nice and succinct and captures what we want to talk about and should suffice for our purposes today. In particular, palliative care is really targeting quality of life for people who are living with life-limiting illness. And it has the sort of triad focus of pain and symptom management, psychological and emotional, spiritual support, and also very much support for the family. Next slide, please. So we work in palliative care, and our interest is, I suppose, research interest is predominantly in delirium. And it is important that you understand what we're talking about when we're talking about delirium. So the best sort of, I suppose, presentation or definition of this is to look at the American Psychiatric Association Diagnostic Criteria. It's a neurocognitive disorder, and particularly criterion A here is attention and awareness deficit. There is also acuity of onset, usually hours to days, and the nature of it tends to fluctuate. There is an additional disturbance of cognition, such as a memory deficit or perceptual deficit, in addition to attention and awareness deficit. And then last criterion E here is the disturbance is directly related to a medical condition, substance intoxication or withdrawal, or often multiple etiologies, as is very often the case in our patient population in palliative care. Next slide, please. So really, delirium is not just solely, doesn't occur solely in palliative care. It just essentially spans all the medical specialties, and is often has been referred to as every man's psychosis, because if you get sick enough, your brain simply won't function, and delirium is very often a consequence of major illness. There has been a huge amount of interest over the course of the last decade, particularly resulting from studies in intensive care, post-operative studies, geriatric liaison psychiatry, emergency department, and also palliative care. So there's a lot of economic drivers as well, because delirium is associated with very negative outcomes in terms of morbidity and in terms of length of hospital stay and mortality. And of course, the demographic changes with an aging population add to this, add to the importance of looking at delirium in terms of research. Our interest has been, I suppose, dates back to 2012, when we had a planning meeting and invited researchers from all over the world, essentially, to participate. And we started, Shirley and I started the SUNDEPS group, which is Studies to Understand Delirium in Palliative Settings. We have now morphed into a sort of a SUNDEPS Sunrise. Next slide, please. And Sunrise refers to studies to understand studies to understand and improve delirium in palliative care settings. We've brought on board researchers from Hull, York in the UK, and from Sydney in Australia, and we regularly meet. Our most recent meeting was ironically yesterday. Next slide, please. So arising from our initial planning meeting back in 2012, we had 8 publications which really reflected the raw discussion that took place during that meeting, and some literature search that took place around the same time or immediately afterwards. And this is one of the papers, an analytic framework, which essentially maps the clinical care pathway of delirium in palliative care and highlights various questions. I don't worry too much. I mean, there are about 18 or 19 questions that arose in relation to the various points in the clinical care pathway. But broadly speaking, we're looking at, on the left end is sort of epidemiology and prevalence, and then screening, diagnosis, and then management, and then outcomes on the far right. Next slide, please. So the sort of domains that arose from the analytic framework looked, as I say, at epidemiology. I've highlighted the items that are most relevant to today's presentation, particularly prevention, the experience of distress on the part of the patient and family, and also we're going to talk a little bit about medications, and Shirley's going to talk about guidelines, and we'll also cover palliative sedation. So these are the sort of pivotal sort of domains that have arisen from the framework pathway. Next slide, please. And this, we basically since that meeting, we published the 8 papers in 2014 in what was called the SUNDEPS series. And since then, we have been busy doing systematic reviews, scoping reviews, and this is just one systematic review led by Christine Watt, who works with us in Bruyère, a physician on the palliative care unit in Bruyère. And this looked at the prevalence of delirium based on published data. And we got a figure of 35%. So essentially, 1 in 3 patients who are admitted to inpatient palliative care units have an episode of delirium. And also in this paper, it's quoted that 88% of patients in the last hours to days of life have an episode of delirium. So it's an extremely common problem. Next slide, please. And this is just a graphic to sort of show you how we sort of view the sort of pathogenesis. Many of our patients have high level of vulnerability, so they have predisposing factors. So an example of a predisposing factor would be age or pre-existing dementia. A precipitating factor, for example, would be an infection. And obviously a protective factor would be if we engage in preventative measures, would help prevent delirium as well. So this is just a graphic just to try and explain. Next slide, please. And this again is another graphic just looking at the outcomes of the main outcomes of delirium, whether it actually reverses completely or partly reverses, or it proves to be non-reversal. Much of this hinges on the desired goals of care and where somebody is at in their illness, and also on the nature of the etiology. Very often the etiological factors are multifactorial. Next slide, please. And we really don't have time to go into detail, thankfully, on the real depths of pathophysiology. But one of the leading theories at the moment relates to neuroinflammation. In other words, if somebody has an inflammatory process that is systemic, and there are inflammatory mediators in the vascular system, transit through the blood-brain barrier, for example, disruption due to hypoxia or ischemia or pain, can result in activation of microglia, which are the scavengers in the CNS, and they may result in neuronal degeneration. And this is one of the leading theories underlying the pathogenesis of delirium. Next slide, please. Now, it's not the only theory, and this is a gross simplification. There are about 7 theories that sort of compete with each other, but also, I think, probably complement each other. And I would draw your attention to neuroinflammation at the top, and oxidative distress. Also, I should highlight melatonin on the right of your screen. Shirley's going to talk to us about melatonin. So these may all, as I say, complement. There may be portions of these theories that are true. It's incredibly complex and way beyond the scope of this morning's talk to sort of go into detail on. Next slide, please. So delirium is certainly distressing. This was a study conducted by Breitbart in New York, looking at patients whose delirium reversed, and they looked at the perception of distress. In other words, patients looked back or thought back, remembered back as well as they could as to how distressed they were. Their spouses rated the perceived distress of the patient, and the nurses rated the perceived distress of the patient. And 4 is the max. So you can see here that the most distressed people by far were the actual spouses. Now, it may well be the patients as well if they could remember the full episode of delirium. But again, just this is evidence that it is a very distressing condition. So next slide, please. Delirium is subdivided. There are subtypes of delirium based on the psychomotor aspect of it, and broadly speaking, divided into a hypoactive, sleepy state, or the opposite of that would be a hyperactive or agitated state. And in many of the episodes, there is a mixed component of both hypoactivity and hyperactivity. The delirium syndrome itself here, I've given you the criteria already for diagnosis, and basically there may be a degree of smoldering before the onset of the syndrome, and there may well be some smoldering. If the syndrome is the fire, then there's smoldering beforehand, or there may be smoldering afterwards. And there's also the possibility that some people may not meet the diagnostic criteria. So I would draw your attention to the agitated component, the psychomotor subtype, or the mixed It will be important in terms of the discussion later on regarding dexmedetomidine. And I think that's my cue to pass over. Next slide. I think I pass over to Shirley.
Yes, thank you, Peter. So I'm going to start to talk a little bit about melatonin, and then Peter will follow up with dexmedetomidine. Just to note that both these medications are currently under investigation. They're not under routine use currently for delirium. Next slide, please. So melatonin has been called the Dracula of hormones because it comes out at night. Next slide, please. So melatonin controls the sleep-wake cycle and our circadian rhythms, and it's produced by the pineal gland. Our endogenous melatonin levels start to rise about 10 o'clock in the evening, peak around 3 o'clock in the morning, and then drop down to about 9 a.m. to our usual low daytime level. Sleep-wake cycle disturbance has been reported in 75 to 100% of cancer patients with delirium. And as Peter pointed out in the previous slide, that this has been postulated as one of the mechanisms in delirium pathogenesis, the dysregulation of melatonin and the associated sleep-wake cycle disturbance. Next slide, please. So this is a couple of studies. They're non-pharma sponsored studies, so investigator-led studies. And it was the top one, the one by Al Armour, that was published in 2011 at the University of Western Ontario, that looked at internal medicine in patients who were over the age of 65. They used a physiologic dose of 0.5 milligrams of melatonin or placebo and conducted a double-blind placebo randomized controlled trial for 14 days. And they found in the melatonin group they had a lower risk of delirium of just 12% versus 31%. And that piqued our interest. Next slide, please. So we set about to conduct a feasibility study. So this is looking at the feasibility of conducting a much bigger proposed randomized controlled trial. And for this, our primary objectives, we wanted to look at recruitment rates and retention rates. How appropriate were the main study outcome measures? Were the study procedures acceptable to patients, families, and the palliative care unit staff, as well as pharmacy? And how effective was the blinding process? Next slide, please. We also had some secondary objectives, and this was to make adjustments as we needed to the main study protocol, to look at feasibility of data collection on risk factors, and we also wanted to implement guidelines on delirium on the unit as well. And because we have a vulnerable population, we want to look at the safety of the intervention. Next slide, please. So at Elizabeth Bruyère, we have a 31-bed inpatient palliative care unit. And this was going to be a parallel arm, single center, double-blind, randomized controlled trial. Our primary outcome for the proposed bigger, like full randomized controlled trial was going to be time in days to incident delirium. So when we looked at sample size estimations, we went with about 15% of our projected sample size. So that left an N of 60, meaning 30 participants in each arm. Next slide, please. And when I was writing this, it went back, it's like you forget all the things that went in to set up this study. So first we had to get a no objection letter from Health Canada, which took quite a time. We were very fortunate the study drugs were supplied by Jameson Laboratories at no cost. And after ethics approval, we set up an independent data and safety monitoring board. Excuse me. And we also had an independent study monitor that reviewed 3 times during the study. Next slide, please. So for our eligibility criteria, patients had to be 18 years or older with advanced cancer admitted to our unit. The palliative performance scale gives you an idea of performance status. So 30% means that you're bedbound but eating a reasonable amount, and anything higher, so 40, 50, 60%, you're much more active, much more mobile. Patients either had to give their own capacity for consent, or else we use a substitute decision maker consent. Patients were excluded if they had delirium on admission, or if they had a known psychotic disorder, but we did include patients with dementia who were able either to give consent or had substitute decision maker consent and were able to complete the tools needed. We also excluded, that's all, that they're fully listed there, but I just highlight towards the bottom, also communication problems that included tracheostomy or deafness, dysarthria, those kind of things. Next slide, please. Informed consent, because delirium is so common on the unit, had to be completed within 72 hours of admission. Our routine assessments, we use a nursing delirium screening scale, otherwise known as the new desk. That's already in routine use on our unit. The nurses complete this every 8 hours, so once a shift, towards the end of their shift. It's an observational tool to screen for delirium. A positive screen on the new desk is 2 or more, and this would trigger a physician to complete a confusion assessment method, a more detailed evaluation for delirium screening. Patients also complete an insomnia severity index. So for the intervention, we used immediate release melatonin, 3 milligrams, or an identical placebo by mouth at 9 o'clock at night. And the study duration was up to day 28, or if the patient developed instant delirium, if they died or were discharged, or if they withdrew from the study. Next slide, please. So this is our study flow chart. So of note, like 616 patients were assessed for eligibility. And that was in order to reach our 60N for randomization. So that's about 10% from those who were assessed that actually ended up being enrolled. So this was why it took 16 months to do this study. If we look in the top box at the right, the patients not meeting inclusion criteria, that's about 400. And 124, that's about 30% had delirium already on admission, so were automatically excluded. And the communication problems, that's N equals 59, was about 15%. And we found, we added into that category patients who had emotional distress. It was just too much within the first 3 days of admission for them to think about and be able to consent to join the study. But the bottom 2 numbers of the exclusion, that's declined contact by the research team, or the patient or substitute decision maker declined to provide informed consent after hearing about the study. That figure was 26%. But we ended up enrolling and analyzing 30 in each group, the melatonin arm and the placebo arm. Next slide, please. So the blue study outcomes is for the melatonin group versus the placebo group. So for delirium, 11 out of 30, that's 37% versus 10 in the placebo group. So a little bit more in the melatonin group, although this was not assessing efficacy, just feasibility. For other outcomes, you see a little bit more higher number, 6 versus 3 withdrew from the study in the melatonin group. And for follow-up, there were 23% versus 37% of the placebo group had a 28-day endpoint. I'll show you the survival times in the next plot. There were no adverse effects noted, and the core study procedures were acceptable. Next slide, please. So this is a Kaplan-Meier plot, and this is for you looking at the first quartile. So the time in days, in the dotted blue line, that's melatonin, so that was 9 days, and for placebo in the red line, that was 18 days. Next slide, please. So our lessons learned from this study was that it truly did use a process of kinesthetic learning. So that's emerging and revising. And because it took 16 months, there really was a big effort was needed to maintain and sustain the standards throughout this feasibility study. Also, because it's the first time we've done such a randomized controlled trial on the palliative care unit, there's really a lot of background needed for infrastructure, navigation and resources, ongoing training and education, and obviously importance of clear communication was highlighted. Next slide, please. So this study, we really felt we assessed the feasibility that conducting a double-blind randomized controlled trial, but we would need to look at adjusting to a larger sample size and multi-site collaboration for a future study. And as I said, this was not powered for efficacy evaluation, but we'd have to watch really closely because there was a shorter time to instant delirium in the melatonin group. Meantime, both Peter and I are co-investigators on an Australian study on melatonin, and they've just finished a recruitment, so we eagerly await their results too. Next slide, please, and over to Peter.
Thank you, Shirley. So I'm going to talk about dexmedetomidine. We've had a huge amount of interest in dexmedetomidine potential use in palliative care. There's very little data published on this, but we have quite a few in our division of palliative care. We've got quite a few people who are dual trained in both intensive care and palliative care, including the head of our program, James Downer, who has sort of spearheaded really the interest in dexmedetomidine or potential for its potential use in palliative care. And we've had amazing, well, I'm just, I don't want to claim any credit, but I have to say I'm actually surprised by the amount of success we've had with grant applications, which is a nice thing to report. We've had support for this study from the Department of Medicine in the Ottawa Hospital, from BAMO, from Tohamo, and also most recently from CIHR. James Downer was the lead PI for this. So next slide, please. So agitated delirium is, as I said earlier, a very distressing condition in palliative care. And I think, you know, the evidence that we have for pharmacological intervention, in other words, to control the agitation or control perceptual disturbance or those distressing symptoms of delirium is very, very slim indeed. And as a matter of fact, some recent studies would suggest that there is little benefit from antipsychotics. And often we have to resort to a deeper level of sedation using medications such as midazolam or phenobarbital. Now, there's a little bit of a wider selection of use of these medications to sedate medications in the intensive care unit. But in palliative care, it has been mainly midazolam and phenobarbital. The problem is when we sedate patients with midazolam or phenobarbital, they really are sedated and it's very difficult to rouse them. So communication with a family at a critical point in somebody's illness is obviously compromised. Next slide, please. How do we monitor sedation if we are going to give somebody deeper sedation? Well, Shirley was the author, the first author of this study, validation study, using the Richmond Agitation Sedation Scale, but the palliative version, a slightly altered version of the RAS, which we call the RAS-PAL. And it looks at the level of sedation or level of agitation. And you can see here from the slide, you know, the upper end is the agitation end, the lower end is the sedation end. So this is used by the nurses to try and conduct a standardized assessment and standardized reporting in terms of sedation. Next slide, please. So what is dexmedetomidine? It is essentially acting, I must compliment Julie Lipinski, I don't know if she's listening in, and Amanda Wolf. Both of them, I've stolen their slides, so they'll look familiar to them. Dexmedetomidine is a centrally active alpha-2 agonist with some sedative, mild sedative properties, and is also an analgesic. And as I said, it has largely been restricted to ICU and anesthesia for short-term sedation. The big advantage or potential advantage in palliative care would be the option of rousable sedation, so that families might be able to rouse a patient and have some brief communication with them, which is often very precious when you're in the realm of end of life. There have been multiple clinical trials of sedation with dexmedetomidine in the intensive care population, and all results have been very positive, looking at both treatment, comfort level, and also prevention of delirium as secondary endpoints. Next slide, please. So to date, we have got dexmedetomidine on the formulary at Bruyère and also at the Ottawa Hospital for the palliative care unit there. We've developed an order set, and we basically have developed standard operating procedures for dexmedetomidine use on the palliative care unit. Sal Kanji and Amanda Wolf have conducted a stability study. So dexmedetomidine is stable for 9 days at room temperature. This is important when you're working in a center outside of a larger center such as the Ottawa Hospital. The plan is, we've discussed use of dexmedetomidine with our pharmacy and therapeutic committees at both sites, and the plan is to conduct a trial of 10 patients at each site and report back within a year. So I think we're at 4 or 5 patients in Bruyère at the moment. So this is all very much in the offing at the moment. Next slide, please. So we want to really conduct a multi-site study, and aiming to get about 50 patients in this study. The head of our program, James Downer, leads the Pan-Canadian Palliative Care Research Collaborative. So there are about 6 sites that have expressed an interest in participating in this study. The objectives would be basically looking at patients admitted to inpatient palliative care units, and we want to evaluate the safety and optimal dose of sub-Q administered dexmedetomidine. Also looking at feasibility, the recruitment level, cost, and also some preliminary data in terms of effect size, in terms of efficacy. We also, 4th item here is a qualitative component, and an important component, looking at family members' perception and also the nurse's perception of the acceptability and the perceived impact of dexmedetomidine on symptom burden and their own experience. Next slide, please. So it's a multi-site study, open label, phase 1-2, proof of concept, dose finding, feasibility, and preliminary efficacy clinical trial, and also with a qualitative supplemental qualitative investigation. Next slide, please. So patients are going to be over 18 years or over with agitated delirium with without a known potentially reversible cause, or in whom the substitute decision maker has requested not to investigate and treat the cause. They will have a RAS-PAL score of 2 or greater in terms of agitation, and they will also have a positive diagnosis of delirium based on the CAM, confusion assessment method. They will be excluded, obviously, if they're very much hypotensive or if they've got a bradyarrhythmia. Next slide, please. The family members included then, and bedside nurses will give consent to participation for the qualitative component of the study. Next slide, please. So the intervention then is a dose of dexmedetomidine starting at 0.2 micrograms per kilogram per hour. This can be titrated up by 0.1 microgram per kilogram per hour, up to a max of 0.7 micrograms per hour. And basically, they will target the RAS-PAL level of -1, which is deeper sedation, 0, or even +1. If somebody is +2 or +4, a +1 on the RAS-PAL is obviously an improvement. So they would be the targets. Patients can receive other sedative medications at the discretion of the treating physician. And once the target RAS-PAL is achieved, the dose is reduced by 0.1 microgram per kilogram per hour daily, and the RAS-PAL is reassessed to ensure that we're maintaining a reasonable level of sedation. Also, we will monitor for opioid requirements, because these patients may possibly need an opioid reduction because dexmedetomidine has analgesic properties. Patients who benefit from dexmedetomidine without any adverse events may actually continue on the medication right up till death. And then those patients who run into serious adverse events or any adverse event where it's considered that we would have to stop, they will have it weaned by 0.1 of a microgram per kilogram per hour every hour until the adverse event abates or dexmedetomidine is stopped. Next slide, please. So the outcomes then, we'll be looking at the total duration of administration, how long the patients will be on it, the dose administered, and the dose at which target RAS-PAL level is reached or achieved. Adverse events we will look for, and these would be the sort of ones that have been reported previously, and that would be a bradycardia, hypotension, and also we will look at skin tolerability at the infusion site. Next slide, please. So this essentially is in big part a feasibility study where the goal is to get 50 patients in 1 year across 6 sites with a 20% eligibility rate and 20% recruitment rate. We'll be looking at trying to get 20 patients at Bruyère and 10 at the palliative care unit in the Ottawa Hospital. Looking at the qualitative component then, we will enroll family members and nurses, an estimated 15 of each using maximum variation sampling. I will also hopefully be able to do a total direct drug cost of dexmedetomidine compared to an alternative first-line therapy as identified by the treating physician. Next slide, please. So I'm handing over to Shirley, who's going to talk about guidelines.
Thank you, Peter, for that. And so we've just mentioned about melatonin and dexmedetomidine. So these are 2 medications still currently under investigation for delirium palliative care populations. Although, as Peter said, dexmedetomidine has been used in the ICU setting. But we mustn't forget about non-pharmacological interventions for delirium. So these include orientation, mobilizing the patients, hearing, vision, sleep-wake cycle, preservation, and hydration, because it's been shown that using interventions for these domains has reduced the onset of delirium in 30% of older patients, so over the age of 65. So that's a significant number. Next slide, please. So linking back to when I was presenting on melatonin, we also wanted to implement a delirium clinical practice guideline on a unit. So I'm going to share with you how we adapted, implemented, and evaluated this guideline. Next slide, please. So the aim of this project was to improve our identification of delirium and the care of these patients and improving our communication. So this was with patients, families, as well as with ourselves within the interprofessional team. At that time, Mira Agar in Australia and from 6 units it was in Australia, had recently published a randomized controlled trial looking at the use of oral risperidone or oral haloperidol versus placebo in delirious patients. And they found that the patients who received the antipsychotics, in other words, haloperidol or risperidone, had worse delirium symptoms than those that received placebo. So this was kind of groundbreaking study evidence. So we went ahead and adapted and implemented, and what was important, it was going to be interprofessional and done in a modular fashion for our inpatient palliative care unit here at Bruyère. Next slide, please. So there's quite a few steps to this. So first of all, we started with conducting a systematic appraisal using the agree-to tool to look at the quality of assessment of delirium guidelines. So we first did that, and we found that there really wasn't a suitable guideline that we could just literally just take off the shelf and implement in our unit. So we selected 4 high-quality and applicable guidelines to adapt. After establishing an interprofessional core adaptation group, I set about developing an interprofessional delirium care pathway. Next slide, please. This is page 2. So as you can see, it got quite involved, and I looked at it and thought, there's no way I can implement this. Next slide, please. And then I reflected on, well, what about all these other symptoms in delirium, such as pain, constipation, nausea, shortness of breath? Is there a way that I can kind of format this guideline so a similar format could perhaps be used for future guidelines that we use on the unit? Next slide, please. And I came up with this. So it's in different domains, color-coded. So you have the screening and assessment, non-pharmacological, pharmacological, monitoring and ongoing education. And at the top, the communication and support. That's the overarching theme that was one of the aims of this project. And at the very top, the little silver line, the delirium management, that was going to be our starter kit. This was going to be a fundamental short module, really to give fundamental delirium knowledge and shared common language for all the interprofessional team, as well as orientate them to the rest of the guideline. Next slide, please. So the next step was to do a guideline content analysis. And we have to do this because the AGREE tool only looks at the quality of the guideline. It doesn't actually tell you what the guidelines say. And to do this, you have to develop a recommendations matrix. And I'd never done this before. And in case you're not familiar with it, if we can have the next slide, please, I'll give you an idea of what it looked like. So basically, you line the guidelines up side to side and compare them. So this is my health question, my key question. I wanted to know what are the recommendations for the management of polypharmacy and deprescribing. And I look in the guidelines and see what do each of the guidelines say on each of my questions. So the guidelines we used were from NICE in the UK, the Canadian Coalition for Seniors Mental Health, which you see as a second one, which is called Pierre's, in recognition and memory of our colleague Pierre Allard, who was on the writing committee for that guideline. And we also compared it with the Cancer Care Ontario guideline because that was a local guideline. Next slide, please. So after this, we drafted and finalized our guideline, and then we had to go about implementing it. I also created a big picture summary, just to, went in the front of all the drug administration records, medication administration records on the unit as a quick reference guide, so point of care tool, and followed by evaluation. Throughout this process, I used a CAN implement. This is a Canadian tool. It's a guideline adaptation and implementation planning resource. And it really was very helpful to use a thin implementation approach right from the beginning of the project, rather than thinking about it right at the end. And it truly was an iterative process. Next slide, please. So a lot of work with implementation. Over 2 weeks, we had multiple 1-hour face-to-face introductory starter kit sessions. So this was for all members of the interprofessional teams. This included the ward clerks and the porters and the volunteers, as well as all the clinical staff. Nurses also had a small, a short module on monitoring at the same time. There were 4 online self-learning modules to be completed, and that depended on your role. So everyone in the team was to complete the non-pharmacological module and how to communicate with a delirious patient. So that was for everyone. The nurses reviewed the new desk tool in the screening module, and then the nurses, physicians, and pharmacists completed the pharmacological module. We also created a delirium patient and family information leaflet, which was bilingual. Next slide, please. It's going to take too long to describe implementation. It was a long journey. So this kind of gives you an idea. I've put in the picture of an old children's board game, Snakes and Ladders, if you're familiar with it. So you go up the ladder, but you go back down the snake. So that kind of gives you a sense of maybe how it felt some days. Next slide, please. The overall completion rate of our online modules was 83%. For our follow-up survey, there was a 32% response rate. We had 10 participants for our focus groups and interviews, and we looked at 40 charts, so 20 before and 20 after the guideline was implemented. Next slide, please. This is just a selection of some of the results from the online survey. So this was based on the SMART model of clinical utility. We also had items from the theoretical domains framework. And this just shows that staff felt it was appropriate, accessible, and practicable. Next slide, please. We used an iterative thematic analysis for the focus groups and interviews, and we found 7 key themes. This was the role of the individual, prior delirium knowledge or experience, the importance of guidelines, the collaborative effort of change, useful elements of the guideline, challenges of facilitating change, and the impacts on practice post-implementation. Next slide, please. For the chart audit, we are looking at the antipsychotic medications and also benzodiazepines that were administered 24 hours before and up to 48 hours after a person was diagnosed with delirium. So we found after the guideline was implemented, there was less use of scheduled use. By that I mean regularly scheduled medications, maybe twice a day or 3 times a day, and more use of PRNs or as needed medications instead. Less haloperidol was used, but there was an increase in as needed midazolam use. Looking at the written documentation, there was definitely an increase in nursing documentation of first trying non-pharmacological interventions. But if that did not work, then moving on, and there was a distressed patient or safety concerns, then moving on to administering medication. Next slide, please. So we concluded that breaking it down into modules meant it could be used, this guideline could be used by all members of the interprofessional team to improve care. And we also put the delirium information leaflet. We've actually set it up on the external Bruyère website. Those are the links there, but if you just go in the search box for the external Bruyère website and put in delirium, you'll find them, the leaflets that are available, all the information there, and you can actually download the versions there as well. Thank you. And next slide, I think it's back to Peter.
Thank you, Shirley. So we're going to finish off with sort of looking ahead and looking into the future in terms of what we might do in terms of delirium research. And I suppose our roadmap was really set out back in 2012 with the analytic framework and the various questions that arose along the clinical pathway of delirium in palliative care. Our group met, our Sundips Sunrise group met yesterday morning, very appropriately Sundips and Sunrise, because originally the Sundips reflected, I suppose, the concept of sundowning, but also Sundips Sunrise is it encapsulates the geographical divide between Australia and Canada, because it was sunrise for us, for Shirley and I, at 7 o'clock yesterday morning. It was sun dips, which is around, I think, 11 o'clock in Sydney. So we did have a very productive meeting. I think we've done a lot of systematic reviews and scoping reviews, and most of us felt rather weary of doing any more reviews, but we did agree to look at one more scoping review. Next slide, please. And that is to look at the whole issue of delirium-related distress. One of the questions that we had previously posed was, you know, how reversible is delirium? Is it fully reversible, part reversible, or simply non-reversible? And that's the sort of medical component, but it's also very, very important to look at what the perceived distress is on the part of the patient, on the part of the family, and also on the part of the nurses who are looking after these patients. So apart from the scoping review, we also all felt very strongly that community palliative care management of delirium is a research priority. There is very little data in the literature on this, and this, you know, I think is ripe for studies for sure. Not an easy one to study, but certainly one that merits better study. And then I suppose the last item on the list, I suppose, is we talked about a Delphi study to try and define relief of distress related to delirium. And that encompasses the sort of clinical or pure, more medical component, but also the supportive interventions used and the perceived benefit on the part of family members and nurses. We will look at following through on the melatonin feasibility study. I think if the Australian feasibility study gives a positive result, the data so far in terms of melatonin is kind of mixed. And if it's a big study in Australia, so if it was very clearly negative, it might send a negative signal to us. If it's equivocal or positive, it will warrant replication, and we will look at doing that in Canada through the Pan-Canadian Palliative Care Research Collaborative. I think that's pretty much it in terms of future steps. I wanted to leave some time for you guys to ask questions or make comments. Next slide, please. It's very important that we acknowledge all the people who have participated in SunDips, all the people who have, a very integral part. I'm not going to name them all here, but there's a long list. Shirley and I have had a really good run with team support, and we want to show our appreciation for that. So I'm going to hand it over to Jasmine, and perhaps you can coordinate if there are any questions or comments.
Yeah, thank you so much, both Dr. Lawlor and Dr. Bush, for presenting today. We do have a question already in the chat box from Serena. How did you determine acceptability in the delirium feasibility study in the palliative care unit? I believe that was in reference to Shirley's piece on melatonin. Serena, correct me if I'm wrong in the chat.
Yeah, I think it came up, the question came in, yes, while I was doing the melatonin. So thank you for your question, Serena. The research nurse and the research assistant took field notes during the 16 months. And we also interviewed the research nurse at the end of the study as well. So that was probably a lot of the data sources. Peter, do you want to add anything to that?
No, I think that captures pretty much, I think that there was very little negative to report, Shirley, as I recall.
Okay, thank you. It doesn't look like we have any other questions that have come in. We'll give it one more second. From Shirley, do you see a future for use of dexmedetomidine and melatonin for delirium at end-of-life care in hospice or community care settings? She also adds, 3 milligrams of melatonin seems like a really small dose given OTC available products usually start at 5 milligrams and 10 milligram availability.
Okay. Do you want me to take the first question on dexmedetomidine? Obviously, we're looking. Our study is a feasibility study, and the next step would be to look at a formal trial. So it's very difficult to sort of jump and say we should all be using it. I think it has. I mean, I'm very excited that it has potential use possibly even in hospice setting. But I think that, we need to demonstrate that with evidence. Shirley, do you want to tackle the melatonin?
Yes, for the melatonin there may be, but as Peter said, the data is not clear yet. So I think we still do need, for palliative care populations, a little bit more evidence there. The 3 milligram was what we found to be available time when we did the study. I appreciate there are larger doses available as well. The Australians were going to use like 2 milligrams as well. I think the challenge, we were trying to balance it with safety for our patients, particularly since it was a feasibility study, and increased, particularly somnolence noted, just to ensure it was going to be safe for our participants. And bearing in mind also though that the other Western Ontario study just used 0.5 milligrams as well. So it's kind of a balancing act. I am, though, interested, like maybe the dose needs to change depending on your age, because melatonin levels do drop as you get older. So maybe that's something that maybe there need to be different doses for different ages as well. So I hope that answers your questions. Obviously, it's easier to give, but I think we just need a little bit more evidence and a bit more idea about what the optimal dose as well, if it seems to be helpful.
Yeah, I would just add that the feasibility study, the signal from it was, if anything, a little bit negative. But this feasibility study was not designed to examine efficacy or really to look at safety in great measures. But I think if you get a negative signal, you proceed with caution. Obviously, we need to look at we need bigger data than what we have. And hopefully the Australian study will give us some initial information in that regard.
That's great. Thank you. I don't see any other questions from our attendees, so I just wanted to thank you both for joining us today and delivering such a comprehensive presentation on delirium, palliative care. If anyone wants to reach out, we have Peter Lawlor and Shirley Bush's email addresses on the slide right now, plawlor@bruyere.org and sbush@bruyere.org if you have any follow-up questions for them. We will be posting the recording, so if you want to follow our social media channels at Bruyere Care, we'll have this up and a summary as well and a recording for those who attended today. Thank you so much, everyone.
Thank you.
Thank you. Bye, everyone.
Bye.